Hello, my name is Laura Nguyen, and on behalf of the authors, I will be talking today about the long-term sequelae of traumatic brain injury. We will talk today about functional and cognitive outcomes, behavioral and psychological outcomes, neurodegenerative sequelae, and mortality after traumatic brain injury. Traumatic brain injury includes a variety of injury phenotypes that are most commonly classified as mild, moderate, or severe. The Glasgow-Coma score defines these injury severities, and there are noted limitations to this approach. However, in the absence of alternative classification measures, commonly reported patient outcomes describe recovery trajectories that start with the initial severity classification and describe improvement or decline thereafter. We describe what is known of TBI sequelae in long-term, 6 to 12 months after injury, and longer-term, greater than 1 year after injury. Functional outcome covers a broad range of areas, including independence, employment, social and leisure activities, maintaining close relationships, and other aspects of daily life. For adults with traumatic brain injury, the core recommended assessment of global outcome in the NINDS Common Data Elements for Traumatic Brain Injury is the Glasgow Outcome Scale Extended. Other recommended measures are the Disability Rating Scale, Mayo Portland Adaptability Inventory, and the short form 36 or the short form 12. Individual areas of functional outcome frequently studied in adults are independence and return to work, and these are a common focus of rehabilitation effort. The GOSC is a clinician-rated scale based on interview with a patient or caregiver, and has an element of objectivity, although it is limited by the reliability of the respondent. As you can see here, a score of 1 is when a patient is dead versus a score of 8 is upper good recovery. Using the data from the negative phase 3 COBRIT clinical trial, Gardner and colleagues defined 7 trajectory classes from a cohort of 1,046 adults with complicated mild to severe TBI. Each trajectory class started at one of the 3 GOSC recovery categories at 1 month. Group A started with good recovery. The majority, A1, n equals 115, of these patients had stable good recovery at 6 months. However, some, A2, n equals 4, experienced dramatic decline. Group B started with moderate disability. Of these patients, 6-month recovery was either a rapid complete recovery, as seen in B1 with n of 71 patients, or gradual recovery, as seen with B2, which had 742 patients. Group C started with severe disability and had 3 trajectory classes, that of dramatic rapid recovery, seen in 12 patients, no recovery, seen in 91 patients, or death, seen in 11 patients. A large multi-center cohort study of traumatic brain injury, TRACK-TBI, enrolled patients with mild traumatic brain injury or orthopedic controls. The percentage of mild TBI patients, there was 1,154 patients, reporting injury-related problems on the GOSC was 87% at 2 weeks, as you can see here on this graph. This decreased to 53% at 1 year after injury. Of the orthopedic controls, OTC, these patients, of which there were 299, 93% reported limitations at 2 weeks, but only 38% at 1 year. The difference in rates of continued limitations between mild traumatic brain injury and orthopedic controls at 1 year was statistically significant. It is often assumed that recovery is complete by 1 year after TBI, that functional outcome becomes more or less fixed, and that the need for intervention is diminished. However, evidence from a variety of sources challenges this concept and suggests that outcomes may evolve and change for either better or worse in the very long term. In patients with moderate severe TBI, functional outcome on the GOSC typically improved gradually over a period of about 10 years. The person's age, race, injury severity, and length of rehabilitation hospital stay were all found to influence the evolution of outcomes over time. For patients with milder injuries, it is assumed that individuals return to normal life by 1 year. However, studies have shown persisting disability in about 25% of patients when followed to 5 up to 14 years after mild TBI. TBI commonly causes cognitive impairments in a variety of domains, most notably attention, processing speed, learning, and memory. There's also difficulties with executive functioning, with that referring to a broad set of higher-level skills, including shifting attention, as well as planning and organizing information to work towards goals. Cognitive problems are among the most commonly reported challenges faced by patients with traumatic brain injury. As with other outcome domains affected by TBI, the cognitive effects of TBI tend to be maximal right after injury, more prominent for patients with more severe injuries, and characterized by a course of rapid or gradual improvement over weeks, months, or longer. Cognitive outcome is assessed with specialized cognitive tests, usually administered by neuropsychologists. These include tests of different cognitive domains such as processing speed, executive function, and memory. It is well documented that moderate to severe TBI causes profound acute changes in cognitive functioning that, despite some expected improvement, may remain impaired throughout or beyond the first year post-injury. Cognitive recovery from moderate to severe TBI tends to be most rapid in the first 6 months post-injury and may not be uniform across cognitive domains. Clinical signs of TBI severity are associated with the degree of cognitive impairment and recovery, in particular, length of post-traumatic amnesia. Historically, patients were often told that they would likely reach a plateau by 6 to 12 months post-injury, after which cognitive recovery would not continue. However, this notion has been challenged by a number of recent studies that demonstrated continued changes in cognitive performance and other outcomes beyond 1 year post-injury. Whereas moderate to severe TBI is commonly associated with persistent cognitive impairments, mild TBI is associated with more subtle and transient signs of cognitive dysfunction. However, the exact time course of recovery observed after mild TBI has varied across studies and subpopulations of mild TBI. As is the case for moderate to severe TBI, there is a dearth of high-quality research into the predictors of cognitive recovery. However, injury severity and involvement in litigation related to the injury are well-accepted predictors of increased reporting of cognitive symptoms and reduced cognitive performance in mild TBI samples. In addition to diminished cognitive function and day-to-day independence, patients with TBI often experience changes in emotional functioning and behavior. Behavioral and psychological outcome is often assessed by tests clearing symptoms of depression, anxiety, and PTSD. Unlike the functional and cognitive sequelae of traumatic brain injury, which are typically most notable soon after injury in an individual with more severe injuries, associations between TBI and psychiatric problems do not scale so consistently with injury severity and remain similarly robust even years post-injury. TBI confers risk for experiencing a number of neuropsychiatric and behavioral problems, including various manifestations of internalizing psychopathology, such as depressive and anxiety disorders, and externalizing psychopathology, aggression, behavior disinhibition, anger, and substance abuse. Personality changes have also been reported after severe TBI, as well as chronic pain and self-reported sleep problems. Although TBI is associated with increased risk versus the general population and sometimes versus orthopedic controls, for a number of psychiatric conditions, the exact prevalence and mechanism of differing conditions is unclear. Depression is probably the most well-established internalizing problem in this population. In patients with moderate severe TBI, for example, mild depressive symptoms are reported at 1 year post-injury, with one sample reporting fatigue, distractibility, anger and irritability, and rumination amongst the most common depression-related symptoms over an extended time frame post-injury. Although pre-injury psychiatric disorders confer increased risk for persistent TBI-related and psychiatric symptoms after TBI, TBI and the concurrent stressors that often occur in a traumatic injury appear to cause new or worsened depression. In summary, patients with TBI appear to be at heightened risk of experiencing myriad psychiatric and behavioral problems, irrespective of TBI severity or time since injury. Such problems often co-occur and are robustly associated with functional limitations. However, the directionality of the relationship between psychiatric problems and functional limitations is unclear, as are the mechanisms of TBI-related neuropsychiatric outcomes. Yet the high prevalence of such problems in this population underscores the need to assess for and treat psychiatric disorders in diverse TBI subpopulations. TBI is an established risk factor for neurodegenerative diseases of aging, including both dementia and Parkinson's disease. And those that experience multiple concussive or subconcussive injuries may be at risk for chronic traumatic encephalopathy. There is emerging evidence that certain populations may be at especially high risk for post-TBI neurodegenerative disease. For example, risk estimates of TBI-associated dementia in the few studies that have focused on military veterans have tended to be slightly higher than the pooled risk estimates from predominantly civilian populations. Additionally, older adults may be particularly prone to dementia following even relatively mild TBI. It is well established that TBI can carry a risk of death early after injury, and patients with severe injuries in particular have an enhanced probability of early mortality. For many years, it was believed that those surviving beyond the acute stage had a normal life expectancy. However, there is now evidence that higher risk of mortality extends into the longer term. Estimates of all-cause mortality risks from the National Database of Patients who have been discharged alive after rehabilitation indicate that patients are more than twice as likely to die than people in the general population, and have a life expectancy 7 years shorter on average. The highest relative risk was seen in younger patients. Increased mortality was observed for a wide variety of causes of death. Evidence for increased mortality in patients with mild TBI is more equivocal. Age was a predictor, and also various personal and socioeconomic factors, such as use of alcohol and drugs pre-injury, previous TBI or physical limitation, and social deprivation. These findings suggest that lifestyle may contribute to higher levels of mortality after mild TBI. If so, these risk factors may be potentially modifiable. Overall, there is not a singular predictive algorithm to determine which TBI patients are at risk for long-term sequelae. This makes prognostication to patients and families challenging. The literature suggests that multiple variables contribute to long-term functional outcome, cognitive dysfunction, development of neurodegenerative diseases, and mortality. A key point is that recovery after TBI is variable and may continue beyond 12 months. Continued research will help define the risk factors to developing TBI sequelae and strategies for early intervention. Thank you.